is will be made by our good friend Laszlo Szegedi. Laszlo was one of the founders of the Thoracic Subcommittee in the EACTAIC, and he is from Brussels in Belgium, and he is going to talk about hemodynamic monitoring and goal-directed therapy during thoracic surgery. Please, Laszlo.
Thank you, Mert, but I'm awaiting the slides. Even here we are. Here we go. So good afternoon, good evening, everybody. Thank you for this nice introduction. This is my hospital. Sorry. This is my hospital, and we are doing every kind and type of surgery and every kind of transplantation. So you are all invited to visit us. You're welcome. Just to say, I don't have any conflict of interest concerning this presentation, but I have a huge conflict with the flying time, because 15 to 20 minutes about hemodynamic monitoring for thoracic surgery, it's mission impossible. Indeed, as you know, the thoracic surgical patients range from the simple healthy adult for a pneumothorax to a patient with severe atherosclerosis and COPD needing a pneumectomy, to patients who are needing lung transplantation. And it's well known that the risk of intra or postoperative complications, or both of them, will increase the length of stay, will increase the costs, and of course, will increase the mortality. Just to remind you, mortality after thoracic surgery ranges from 1% for a vessel resection, to 4% for pneumectomy, to 6% for lung transplantation. That's a 30 days postoperative mortality, as compared, for example, to a CABG, to a coronary artery bypass graft, which is only 1%. Sorry to say only, but that's the truth. So it's not surprising that reducing these risks is important for sure for the individual patient, for us too, but for the healthcare planners and for the managers. And of course, the insufficient tissue perfusion is most of time during thoracic surgeries due either to hypovolemia or to heart dysfunction or to both of them. Thus, an adequate perioperative management, and I will say with an effective and timely hemodynamic monitoring, can reduce the risk of complications and potentially improve outcome. But can and improves is really conditional, because it's not yet fully demonstrated for thoracic surgery. In this article, published a couple of years ago, it was a survey for ESA and ASA members. What hemodynamic monitoring do you routinely use? You can see that the respondents answered either from America or from Europe. They're using more than 90% invasive arterial pressure monitoring. Almost 80% central venous pressure monitoring, and very, very few were using, let's say, more sophisticated monitoring devices, like the non-invasive monitoring devices, actually, that we have on the market, and transesophageal echocardiography, maybe echocardiography because the lack of the skills and the knowledge to do so. Just a reminder, it's not a rocket science, but it's clear. It's some results of the Las Vegas study that open surgery has more hemodynamic adverse events than endoscopic surgery. As you can see, 36% as compared to 70%. So it's more than twice. As well as high-risk patients are more prone, 4 times more prone to hypotension than low-risk patients. Here is a summarizing of the risk factors for hemodynamic events during thoracic surgery. You see the 4 risk factors. Each risk factor has some points. And when adding these points, we will get a score, a scoring system or class system if you want. As you can see, 2 of them added, so a patient with 2 of them is already a complication risk, a cardiac complication risk of above 20% during thoracic surgery. Now, moderate fluids during fluid management for thoracic surgery is the common recommendation nowadays. But especially in some risky patients, goal-directed therapy, the famous GDT, can be a more reliable approach than just the moderate therapy. The problem is that there are no studies in thoracic surgery with GDT, and the studies presented are some retrospective, very heterogenic. It's not a secret. Hypo or hypervolemia are bad. Extremes are always bad. In this paper, published by Pelosi, Jean-Louis Vincent, and other intensive care specialists, they assessed hemodynamic monitoring too, and they found that one of the most accurate and in the meantime most invasive was the pulmonary artery catheter. So what would be fine to have something at the opposite side in the green zone there, where the best is marked, something really not invasive, but the same accuracy than the pulmonary artery catheter, which is in brackets, I will say, it's 52 years old already. Again, not a rocket science. The higher the risk, the more invasive the monitoring. Let's go back to thoracic surgery. In thoracic surgery is most of time done in the lateral position. Most of time, not always. And this is a pictogram from the last thoracic anesthesia textbook edited by our friend Edmund Cohen from the Mount Sinai. It shows really clearly that a non-invasive arterial pressure monitoring in the lateral position will either over or underestimate the arterial pressure value, while an arterial line not. So everyone knows the arterial, the invasive arterial curve with its systolic pressure, diastolic pressure, of course, the mean arterial pressure. I am not here to say you basic details of it. And of course, the distance between the systolic and the diastolic is the